We're going to start respiratory emergencies. So of all the things that we do, I think of everything that we do in EMS, one of the most important things we deal with is respiratory emergencies. If you can't breathe, life is bad. How many of you guys have done asthma? Almost everybody, right? It's probably one of the most common complaints that we have. How many of you have been on a respiratory call that goes bad? They generally, when I get that type of call, when it's a real call, when it's somebody that actually can't breathe, that's the kind of call as a medic, even as a paramedic, that's kind of scary. Because that call, somebody's already sick, and they're either going to do one of two things, get worse or get better. So, as silly as that sounds, you have to really work at getting them to get to the point where they're better, but if they start to get worse, that call just circles and it gets bad quickly. And anybody who's been a part of those knows that that's what happens. How important is BLS in this? Okay, every time I've done a lecture here or anybody, or anywhere on these types of subjects, I always talk about BLS interventions. What's important about BLS interventions? What you guys do. First one's there. So you make or break the call. There's a difference between you guys getting there and saying, have the medic slow down, to getting on the air and saying, you know, we need to have them here immediately. We have such and such. It's important as a medic. People debate this, but I like to hear what it is you guys think before I get there. Why? I can start to think in my mind. So if you say, I'm on the scene of a 23-year-old asthma, then in my mind, and you're telling me, you know, they can't breathe, or wherever the call seems to be going from your perspective, it starts to get me thinking in the direction of what I want to do. Because I have a lot of treatments available. I have a lot of drugs available, I have a lot of procedures available, so I can look at the call and start to think before I get there, you know, what I want to do. Now, all of you guys that run on the ambulance, Ron, what do you think the importance is of preparing before you get to the call? It's always important. When you're going to an MBA, when you're going to an MBA and you're driving along and they say you're going to have 3 patients and one guy has to be extricated and 2 people are on the side of the road, you start to think in your mind before you get there, either consciously or subconsciously, what are you going to do? Right? So you're like, oh, I need another ambulance because I need more boards. We're going to do rapid takedowns on these. We're going to do this, and so forth and so on. So on respiratory calls, I like to know what's going to happen beforehand so I can start to prepare myself for what I want to try to accomplish. So what you guys do is very important. We'll start with these slides. I haven't looked at these. I apologize. But, see me? Yes. So dyspnea. Common complaint encountered in the field. I think it's probably the most important, the most common complaint is difficulty breathing. That and chest pain. Where does difficulty breathing come from? So it can come from anything, common cold to asthma to a heart condition. So let's start. When you have a cold, can you have difficulty breathing? Sure, why? Congestion. People think that's not difficulty breathing. Anybody who's had nasal congestion, you're trying to breathe, you can't. Do we breathe primarily through our mouths and nose? Primarily through our mouths, but you need the nose to be able to supplement it. So what happens when you get really stuffy? You can't talk, you can't move around a lot, because when you start to move around a lot, you tend to start to breathe through your nose. So also colds do what? They can, when you start to get a lot of congestion in your lungs start to be, the vessels in the lungs start to constrict. Tidal volume goes down. That's, well, when you get older that happens, especially with the cold. But even in younger, how many people here have used inhalers when you have a cold? It's pretty common now. They give you albuterol or one of those to help open things up. Asthma, what is asthma? Asthma, what's asthma? Right. So asthma is a condition where things start to constrict down, where the bronchioles start to constrict, and you can't get air. Is it an air coming in problem or out problem? Out. It can be both. Primarily, it's an out problem. When we classify this, we classify it within the disease processes that are out problems. But it can be both. Heart problems. What happens with that? This is what I find most interesting. Why can't you breathe if the problem's with your heart? Congestion in the lungs. How does the heart work? What do you need? Oxygen, right? So when you think about this, if you start to have a heart problem, your heart's not pumping properly, or your heart, most important, you're having a heart attack. The heart's not getting enough what? Oxygen, because it's not getting enough blood, right? So we'll quickly go through anatomy, right? You take a breath. What happens to the oxygen? So we know there's oxygen in the air, right? How much is in the air about? 21%. Good. Everybody knows that one. Even I remember that one. Okay, so 21% is in the air. You take a breath in. Amongst other things, the important thing that you're getting is oxygen in your body. It goes into the lungs. How many lungs do you have? 2, right? So you take air in, it goes into the 2 lungs. There's a couple of lobes on one side, there's 3 lobes on the other side. That's not important. Which one? Yes, I do know, but it's not that important. You get oxygen in the lungs. What happens then? The oxygen breaks down, goes into your bloodstream, goes from one side of the heart, pumps blood that doesn't have oxygen, goes to the lungs, picks up the oxygen, drops off the bad stuff, goes to another side of the heart, left side of the heart, pumps the blood out with all the oxygen, and that goes throughout your body. In addition to going throughout your body, it goes to your heart. It supplies the heart with oxygen. So if the heart is not getting oxygen because the vessels are small, or they're damaged, or there's clots in there, your heart's not going to get enough oxygen. Your body's smart. When it doesn't get enough oxygen, it says, I need more oxygen. So what does it do? Anybody who's been on a heart attack call, how do people breathe? Fast or slow? Fast, right? They're working to breathe. They're sitting there, they're going, I can't catch my breath. Because the brain. Oh, you got it.
Guys, can you get off your phones in the corner, please?
So your body can't get enough oxygen in. And when it can't get enough oxygen in, it starts to tell the brain to make you breathe faster, deeper, and it gives you that feeling of not being able to catch your breath. Anybody here run track? Okay, I run. What happens when you run really fast? You get tired and you can't breathe. Well, you get tired, yeah. You get tired and you can't breathe. Well, picture having that feeling, but not running. Just because your heart can't get enough oxygen, and that's what that feels like to somebody who's having a heart attack. Or to some people. Even though, now when you look at somebody that say they're having problems breathing, and you may not know what's causing it, as an EMT, you have things that you can do to make them feel better. So what are those things? Oxygen, even before oxygen. Position. That is probably the single most important thing you can do. I'm sitting there and I'm like, I can't breathe. And then you go, well, sit up. Oh, wow. That feels better. Because you can breathe better when you're in this position. When people can't breathe, they sit forward in what we call tripod position, because it helps expand the lungs. So putting people in the right position will help them breathe better. It will help them maximize breaths and maximize the amount of oxygen that goes in. And that's something you can do right off the bat with nothing. Oxygen. How do we give oxygen? Memory breather. Usually, now you'll have medics come along, the medics will say, put them on the nasal cannula. That's because we have other tools available. It's not even always right. But initially, on any call, even, I work BLS on the volunteer truck occasionally, and when I do that, the first thing I do when somebody tells me they can't breathe is normal breather, 10, 15 liters per minute, see what happens with it. And that's something you could do immediately, and that's what they need, right? That's what's going on with them. And also, if you do that quickly enough, you may save a life. And I may figure out why this isn't there. That's okay, so causes. Causes of problems breathing. This is getting down into what happens in the lungs. So getting oxygen into the lungs, one problem. If I go like this, I'm not going to get oxygen in, can't breathe, right? Exchange of oxygen across the alveoli membrane, smoke inhalation fluid, what does all that mean? When you take oxygen in, so picture the lungs, right? The lungs are like a big sack. Within the lungs are structures to help absorb oxygen. Anybody ever see them? Alveoli, what they look like? You seen the pictures? Yes? Look like little, like they always portray as like little like grapes or ping pong balls. I'm sorry?
Cotton balls.
Cotton balls. They look something similar to that. So when you take the oxygen in, what happens in that area is the oxygen molecules go in. There's membranes in there, and actually down at the blood level, the capillary level, things exchange. So oxygen, which is good, comes in, and the carbon dioxide goes out, which is the bad stuff. That exchanges. So if you're not able to get oxygen into those cotton balls, then you're not going to be able to breathe well because there won't be an exchange. Fluid, smoke inhalation. So if you inhale smoke, what happens? How does that impair the ability to do that? Soot, right? So if this area is where you want to exchange it, and I put a towel over it, or soot over it, you're not going to be able to exchange, right? Does that make sense? If you put fluid there, like pulmonary edema patients, people who get fluid into their lungs, or drowning patients, you put fluid there, do you exchange oxygen? No, there's something that gets in the way. So that's another way where you might not be able to breathe well. Transport of oxygen to the cell through shock. If there's all of this takes place in blood, right? So we're talking about that with the heart. If the heart doesn't get blood, then there's no oxygen. If all the tissues in your body don't get blood, then they won't get oxygen. So if you interfere with the ability for blood to circulate through the body, then the oxygen is not going to be distributed. That makes sense. When could that happen? During what? Shock. Right? So if somebody has a car accident and they're losing blood, if there's no blood, what goes along with the blood? If they're bleeding, the oxygen is dissolved in the blood, so that goes away. So it's another way where you might not be able to go get oxygen. Interestingly, what happens when you have somebody who's going into shock? What happens to their heart rate? Goes up. Okay. What happens to their respiratory rate? Goes up. Which one happens first? Respiratory rate. In general. Now, there'll always be exceptions. But in general, if you see somebody who starts to initially becomes tachypneic, that's the first thing, one of the first signs. Then next would be heart rate, and then what happens to blood pressure? Blood pressure goes down, right? Exchange of oxygen and CO2 at the cellular level, that's just where it takes place in the cells. All of this ultimately takes place small. You guys all have taken bio, right? So when you look at the cell, all the oxygen and the exchange of things take place. Mitochondria does some of it. Lysosomes, I believe. Remember correctly? Transport. Is it working? Signs of respiratory difficulty. So give me some signs. This stuff is all basic. Give me signs. Tripod position. Okay, position. Rate depth. What does that mean? How fast, right? Somebody stand there going, I can't breathe. The depth. Either they're taking deep breaths in or what? Shallow, even worse. That's like when somebody's getting really bad. Skin changes. What happens to the skin? Dusky. What else? Cyanotic. They start to turn blue. What turns blue? Lips and nail beds. Right? You see the nails? Anybody seen that? You guys have all seen that, right? It starts to turn blue here, the lips turn blue. Lung sounds. So what kinds of lung sounds do we get? Wheezing, most common. You could be easy. Wheezing, what else? Rails. What are rails?
It's like fluid in the bottom.
Fluid in the lungs, what does it sound like?
It's like crackling.
Crackling. People describe it in a whole bunch of ways. Crackling. Hair between your fingers. Well, hair between your fingers. Whole different ways that people describe it. Stridor. Anybody ever have an asthmatic that's really bad? They start to make very loud noises. Difficulty speaking. That's probably the most important thing. If I tell you somebody, have you ever heard the term like 1 to 2 word dyspnea, 3 to 4 word dyspnea? Does that sound familiar? Sometimes you hear it, people don't know what it means. So basically like 1 to 2 word dyspnea, it's how many words can you say before you need to take another breath, basically. So if I can only take 1 word at a time, how bad is that? It's pretty bad. If I'm talking like I am now, there's a big difference between those calls. So if you get on a scene and you say, what's the ETA on the medics, because we need them here now, and you say over the air, the patient has 1 to 2 word dyspnea, then I'm like, oh man, my night's going to really be bad now. The patient's night's going to really be bad. And if you say the patient's speaking full sentences, then you know that you might have a little bit of time. So when you give a report, in general, you hear a lot of the medics say, patient's able to speak full sentences, or patient has 1 to 2 word dyspnea, 3 to 4 word dyspnea. That's how you kind of can tell how bad somebody is. And if you think about it, think about any difficulty breathing call you've been on. When the person's really bad, they can't get a word in without taking a breath. So if nothing else, remember that. When you see somebody doing that, that's bad. That's really bad. They might not even let you put an oxygen mask on. Why? Because they freak out. Because now they're hypoxic. When you don't have oxygen, it goes up to your brain. When your brain starts getting deprived of oxygen, you start to become combative. People become claustrophobic. You try to bag them, and they start pushing your hands away. That's when that call is starting to get bad. Coughing, people cough why? People cough for a whole bunch of reasons, but difficulty breathing. Trying to clear things out. So if they have fluid, they have bronchi, they have an infection, any of those things, they'll cough a lot to try to get rid of it. It's the body's reflex. Positioning. Really important, just sitting the patient up. When you can't breathe and you start to go in that bad circle downwards, people start to lose the ability to sit upright, and you'll see, especially if I'm on a call, you'll see me, I'll start to pull people up and push the stretcher bolt upright to get them sitting up. Fluid drains down, right, if you have a cup of water. So if there's water in their lungs and you sit them up, where's the water going to go? Down here, and you'll exchange oxygen here in the upper parts of the lungs. So sitting them up will do that. It helps expand the chest. So that's a single thing that you can do that really makes a difference for these patients. Level of responsiveness. So, one of the things I will tell you, teaching this, if you were normally alert, like you are now, it's like, oh God, don't do that. So if you're normally alert, what's your name? You know what day of the week it is? Where are you right now? Okay. If he answers those questions, that means that his brain has two things. Two things your brain has. What are those two things? Oxygen and sugar. Oxygen and sugar. Your brain needs two things to survive. When SpongeBob. But sugar and oxygen. So if you can answer those questions, in general, your brain has blood because it's circulating. It has oxygen and it has sugar. If I ask you what your name is and you go Robert and I say, you know what day of the week is and you're confused, and I ask you where you are right now and you're not sure, that means something is not working up here. When you're hypoxic, you're not getting those things here. So now he may not be answering those questions appropriately. So if somebody says to you, they call you and they're an asthmatic, and I say, what happened today? And you know, I called, I'm a family member and I called for Emily. No. Kathy. No. So I'm a family member and I call and I say, she, you know, normally she acts normal and now she's one of these things, restless, sitting in the chair, can't get comfortable, confused, combative, throwing things. Anybody ever have an asthmatic that gets combative? You ever seen that? That's really when you know that things are getting bad. She's doing those things, that means her brain doesn't have enough oxygen. So the number one thing, one of the important things you can do when you're doing your assessment is establish that they're conscious and that they're not confused, they know where they are, who they are, they're not restless, they're not confused, and they're not combative, they're not fighting you. Degree of distress, struggling for breath, sweating, ability to speak, we talked about all that. Concentration, skin condition. Skin condition, when you start to get scared, what happens? What do?
Perspire.
You perspire because you start to activate which system? For the EMT. Fight or flight, which is your sympathetic system, right? So you guys know what fight or flight is, right? So you start to activate that system. What happens? People start to sweat. Their skin gets cool, and they get that cool and clammy feeling, or that cool and clammy when you touch their skin, they're kind of cool and moist. That's because your body starts, if you can't breathe, your body initiates the fight or flight. So that's why people start to get there. Is that an early sign or a late sign? It can be early. People start to know that they're in trouble. They start to know that they can't catch their breath, and they start to get nervous. Their body knows, their brain knows that something is wrong, and starts to initiate that. Nasal flaring, what's that?
Red nostrils.
The nose gets bigger. People start to try to take deep breaths in, and the nose gets bigger. Tracheal tugging. Adam's apple starts to pull down. Actually, down or up. You'll see it. Intercostal muscles are what?
In between the ribs.
Ribs, right? How do you breathe? What do you use? Ribs. So these muscles, they pull out. When you start to use those, you start to do this, and you go. You're using all the muscles you can to expand your lungs. Accessory muscles in neck and abdomen. Neck. These muscles here start to pull up. Who has seen this on a patient? Most anybody that's ridden has seen something along those lines. People, they do this, because what are they doing with the lungs? Pulling it up and out to try to get as much air as they can into the lungs. So questions, what do you want to know? The boring things we have to ask. Onset, when did it begin? Proposed, what brought it on? So if you, an asthmatic, what brings on like asthma? I'm allergic to cats, I can't get close, you have a cat. I can't breathe, And when they get here and they go, what happened? Oh, I was in the room, I started to have problems breathing because there was a cat. Suddenly, so things that happen quickly as opposed to over time. Anybody know a condition that happens over time that we deal with all the time, or that we deal with on a regular basis? COPD. That's when I'm trying to figure out what's going on with somebody, that's a very important question. How long has this been going on? Well, I haven't felt good for about 2-3 days, and then today it just suddenly, or today it started to get worse this morning, and now it's 3. And now I'm really having problems breathing. COPD does that, emphysema, people who smoke, or used to smoke or whatever. That's something that goes generally over time, and then they call when it gets too bad for them to be able to manage on their own. They always have shortness of breath, but there's periods where it gets worse. Things that could make it worse would be like they have a cold, or they have pneumonia, or the weather is cold. They went outside and the weather causes them to be sick. So that's something that occurs over time. Sudden things would be asthma, generally. Somebody's fine that has asthma, and then they run, and then they get an asthma attack. Something happens suddenly. Pulmonary edema, generally. People who have congestive heart failure, and then it turns into pulmonary edema. That occurs suddenly. Heart attack. Somebody has an MI, right? Sudden. They were fine in the morning, and then by the afternoon, all of a sudden, they couldn't breathe. What makes it better? Well, what we talk about things that make it better. If I sit up, it feels better. If I use my inhaler, things like that. Orthopnea. What's orthopnea? Orthopnea is pillows. I forgot what they have there. Orthopnea is, I'm sorry?
Sit up to breathe.
Sitting up to breathe. So you walk into somebody's house, and it's 3 o'clock in the morning, and they're sitting in a chair in the living room. And you say, what happened tonight? Well, I was sleeping in my chair. Do you always sleep in your chair? Yeah, I can't sleep in the bed anymore. It's pretty common within a certain group of people. Or you go into the bedroom, you find them sitting on the bed, and they have, not decorative pillows, but a whole bunch of pillows. So they have like 8 pillows on the bed, 6 pillows, 4 pillows. Do you sleep flat? No, I haven't been able to sleep flat in 5 years. Why does that happen? What kind of patients have that? Fluids. So those would be congestive heart failure patients. Pulmonary edema is what it becomes, but it would be a congestive heart failure patient. Quality. What does the breathing feel like? So I usually use 2 questions myself. Does it feel like you can't take a breath in? Mechanically you can't take a breath in? Or does it feel like you just ran a marathon? Those are 2 questions I use to kind of gauge it, what's bothering them. So mechanical patients, people who, diseases where people have a problem taking a breath or getting the breath out would be COPD, asthma. Those kind of patients, they're working to breathe. They're physically working to breathe. So asthmatics go, they can't get a breath out, they have trouble getting a breath in. Whereas patients like congestive heart failure patients, heart attack patients, they actually feel like they just were running from what they describe. So I use those 2 questions to kind of get an idea of what the quality is. The other thing would be patients with embolus, with pulmonary embolus. People have pieces of clots that go into their lungs. They can feel either one. Some of them feel like they can't breathe, some of them have pain when they breathe, and some of them feel like they can't catch their breath. And all of those kind of make sense within that profile of disease. Have they ever had this before? Best question you can ever ask. Hi, how are you? What happened tonight? Can't breathe. You ever had this before? Yes. What was it? Asthma. Does it feel like asthma tonight? Yes. Okay, we're done. Right? People make this very complicated. And it's a very easy way to tell what's going on. ask the patient. When I went to paramedic school a couple of years ago, the doctor, I'll never forget the doctor at the hospital I did this at in New York City, stood in front of a room and he said, the patient will always tell you what's wrong with them. You just have to ask the right questions. And I to this day, always remember that. That's true. You ask them what's wrong, they'll give you, if you ask the right questions, you'll get a good idea of what's going on with them. Because they can tell you what they feel like. How many of you have ever gone to a doctor or talked to a teacher or whatever and felt like that person had no idea what you were talking about because they weren't listening? Everybody in this room, right? Parents. I always felt that way with my parents. When you're interviewing a patient, try to look at it from their perspective and give them time. Ask them the questions. How do you feel? What does this feel like tonight? And have them give you an actual answer that you kind of consider. Some people, you ever work with somebody? What's wrong today? I have chest. Okay, how long has it been? Wait, I didn't finish. And they don't get the answer out. So give them time to tell you and then try to put it into perspective of what it might be. Severity, if it's chronic, so we do this all the time. You have asthma, right? Asthma patients, allergy patients. I have bad allergies. When you ask them, you know, if you had this before, how does it compare? You ever had somebody tell you, hi, I have asthma, and then they look kind of anxious? You say, how bad is this compared to other ones? Oh, this is pretty bad. So either one of two things. It's a really bad attack, or maybe it's not bad. Every once in a while, especially with the elderly population, they'll think it's one thing. So you go to their house and you say, you know, what's going on today? And they'll say, oh, it's my asthma. And then, well, what made you call today? And they're like, oh, this is the worst asthma I've ever had. And you ask a couple of more questions, and you realize it's not asthma, it's something else. So comparing what things were before give you an idea of what it might be. When did it start? Undergraduate, associated things. Can't breathe. What do you think something is if I tell you, I really feel like I can't breathe, I've been coughing for 3 days, I've had a fever, pneumonia, cold, I'm whiny. Nobody's paying attention to me. Look at me, I'm sick. I actually do, I'm sick. So if somebody who's coughing a lot, who has a fever and all that, you think one thing, it's a cold or it's pneumonia, versus somebody who maybe this just started and it's could be pulmonary edema or a heart attack. Smokers, you know, if they smoke all the time and they say, you know, this is out of the ordinary. You're normally I'm short of breath, but today it's not like it is normal. Breathing patterns, we could do an hour on this, just that part alone. You know that there's different ways people breathe. How many people are EMTs here? Just so. Okay, so give me some breathing patterns. Give me some breathing patterns. Chain stoves. When do you get chain stoves? Head injuries. Yeah, I'm always kind of confused with that. There's like biots and chain stoves. There's a whole bunch of names for these. Different things that happen cause your breathing to change in pattern. So do you understand what the pattern? If I go, that's pattern breathing. What are you breathing like? A deep breath, rhythmically over time, or shallow breaths, quickly? That's the rhythm. They mean all sorts of things. I don't think it really helps as much as people, like I've never looked at somebody and said, you have chain stoves. I know you have a head injury. I've gone that way. I mean, it's usually the other parts to it that tell you what's going on. Too fast, too slow, and not at all. So usually what I look at, the things that I think are important, mental status, what is the patient's mental status when compared to normal? What are they like normal? He's normally alert. He keeps going, don't pick on me. Normally he's alert. Today he's not alert because he's had problems breathing. That's a big indicator. How quickly are they breathing? Color? Are they blue? Are they cyanotic? Because then I know there's a problem. What does it look like? Do they look like they can't catch their breath? And how many word dyspnea? If somebody is at 1 or 2 word dyspnea, that's a patient I need to start heading towards the big box. It says hospital. That's a patient I need to get there and start doing stuff as I go along. Ratio of inhalation to exhalation, what does that mean? They talk about this a lot, and the only reason I tell you this is because you'll see it and people go, oh, that's nice, and they have no idea what that means. What it means is, how many seconds does it take, really, to get a breath in versus to get a breath out? So, there's actually a ratio. What it should be, what's the ratio? 1 to 3, 1 to 2, we should be normal. When people start doing it equal, or it starts when they're fighting to get the breath out, so what would that look like? Asthmatics breathe like that. COPD patients, people who smoke, who have emphysema, breathe like that. You see them? That's the ratio of inhalation to exhalation. If it's too long on the back end or on the front end, then there's a problem. How will you know that? In the field. You get to somebody's house, how do you know? What does it look like? No magic to this. What does it look like? When I go in and I interview, or I'm looking at a patient, I'm going to watch him breathe. And I'm going to go, wow, that looks normal. I'm going to go, oh God, that doesn't look normal. Or, oh wow, I need paramedics. Wait a minute, I am the paramedic. So I'm going to look at somebody, and you know when somebody's not breathing well. When you walk into somebody's house, when you're doing the call, is there any question in your mind when somebody's not breathing right? You generally know it. So all of that stuff really is the mental portion of this. But you know walking in whether somebody's sick or they're not sick in terms of breathing. Prolonged inspiration, obstruction of the upper airway. Somebody's choking, right? We do these every once in a while. You do partial choking. Somebody ate a candy or they ate something and it's blocking the airway. They take a deep breath in to try to push air through that. When they have prolonged expiration, which is breathing air out, it's obstruction of lower airways, which is things like asthma, emphysema. Rails, fine crackling, bubbling sounds, CHF, pulmonary embolism, pneumonia, forces sound more fluid, or it can also be from an infection, like one pneumonia. How do you know what rails are versus, all of these things are just names. When I teach this in the paramedic course, I teach this, it's just a name. So we get hung up, when we talk about rails, what are rails? Crackles, what disease do we associate it with? Pneumonias, pulmonary edema, that's generally. When we talk about bronchi, what do we associate it with? Bronchitis, coughs, colds, wheezing, asthma. Can you have any one of those sounds in any one of these diseases? Absolutely. Some people who are in pulmonary edema actually have a wheeze. Some people who have colds actually have rails, pneumonias. How do you determine which is which? People get very hung up on the sounds. So here's the magic for this. Remember what I told you about patients will tell you what's wrong with them? Right? Patients will tell you what's wrong with them. So if you tell me, I've been coughing for 3 days, I've had a fever, and I stayed home from school. What am I thinking? What are you thinking? What are you thinking? Pneumonia, something like pneumonia, right? Okay. when you listen to his lungs, you think you hear rails, does it change the fact that it's probably a pneumonia? No. If he has a little bit of a wheeze, does it change the fact that it's probably a pneumonia? No. You start having sudden onset difficulty breathing, and you say, I'm using my inhaler and I felt a little bit better. What do you think it is? What do you think it is? What do you think it is? He's using his inhaler. Asthma. So, I think it's asthma. So what if I tell you that maybe you hear some wrong out? Does it change the fact that it's asthma? No, it's just a finding. It's just a finding. I tell you, you're a 75-year-old woman. You're sleeping on 8 pillows at night, and your ankles are swollen, and you take a water pill. What do you think it is? CHF. What if I tell you that you hear a little bit of wheezing? Still doesn't change the fact that it's CHF. That's just part of your physical exam. People start trying to classify disease by their lung sound. It happens all the time. I go to a call, somebody says, they have wheezing, they must have asthma. And I look and I go, they got a cold. Because they're trying to associate the lung sounds with the disease instead of talking to the patient and listening to what the patient says, and then correlating that with the physical exam. You can have wheezing with any one of these, you can have bronchi with any one of these, and you can have rales. It's what the history is that determines what it is. And ultimately, what do we do for it? You set them in a position where they can breathe and give them oxygen. Step on the gas. Yeah, pretty much. That's what gets it better. Even when we get there, most of what we do is geared towards making that oxygen maximize, which is what you're doing by positioning them and giving them oxygen. Is that clear? Does that make sense? Every time you go to a patient who has difficulty breathing, ask them questions, figure out in your mind what it is, and when you listen to the lung sounds, try to put that lung sound as to why that's happening within that patient. Snoring, partial obstructions, that's things like, what's the most common cause of an obstruction? Well, yeah, actually, I'm sorry, I wasn't thinking, I was thinking the lung, I was thinking the tongue, because people go to sleep and their tongue goes and they get snoring. But you're right, hot dogs is one of the most common. I didn't think of that, that's good. Gurgling, fluid, people who choke, people who get drunk, snore, they gurgle because they swallow fluid. Stridor. When we say stridor, that's a high-pitched sound. Where does that come from? Closing of the airway. So if you had if the airway is supposed to be this big and I make it that big, it makes the sound high-pitched, right? Odors of the breath. Fruity odors indicate what? The classic hypoglycemia. There's also a lot of things that do it. I try to never get that close to somebody that I can smell that, but alcohol will cause it, other things will cause it. Children. So kids, retractions above the sternum. That can also be with adults, especially the elderly, who get thin and frail up in this area. When you have a kid, when the kid their chest is caving in, they're pulling up on their neck, they have retractions between the ribs, that's bad. That's a bad sign. How quickly do you want to get to the hospital with a kid? Quickly. Adults stay sick for a while, and then they die, right? Kids get sick, and then all of a sudden, they start to go downward. Infants. Does that make sense? Everybody knows that? Kids are what you really... So when a kid has a problem breathing, it's something you want to really start to get going. It's not something you want to be waiting in the house. Feed us around or start to get going towards the hospital. Cyanosis is late finding. Okay. Kids get cyanotic. I mean, usually when you get there, if they've had problems breathing for a while, they will probably be cyanotic. If it really is truly difficulty breathing. So you give oxygen as much as you can and get out of there. Sorry. Cough may, for children, a cough may be pneumonia or asthma. I mean, a cough in a kid can be anything. It could be beginnings of asthma, it could be the beginnings of an infection. I mean, kids, it's hard to evaluate kids. Usually it's history, and even the history is not always good. Sometimes you'll get a kid that's like very young and they'll say they have asthma, but some doctors will tell you that you can't diagnose asthma in a very young kid. It doesn't make a difference at that point. Give them oxygen and get them going towards the hospital. Or get them going towards, treatments or, somebody who can provide treatments. Colds, we know what colds are. Diphtheria, when contact with fever, probably. Pneumonia, everybody knows what pneumonia is. That's a cold that got really bad, or a cold on steroids, basically. So you got infection in your lung, you don't clear it, it starts to multiply more, and it involves more of the lung, and now your body's unable to fight it at that level, or it's having a hard time fighting it. Who generally gets pneumonias, and anybody can get pneumonia, but where do they become bad? Elderly, people over 70. I think, if I remember the statistic right, 70 or 75. That's the most common cause of death. So you have a little old lady that falls. We do this all the time, right? Somebody falls at home and breaks their head, and then you find out a week later that they passed away. And you're like, they were fine. We went to the house, they looked okay. All they had was a broken hip. Once they're in the hospital, they acquire some infection in their lungs, and then they're unable to fight it. So pneumonia in the elderly is pretty serious. As an aside, I try to never RMA those patients. I always try to bring them to the hospital because they need antibiotics. They're not fighting the infection. So people over the age of 70, 75. And it can make them wheeze. People get pneumonias, wheeze. They actually their oxygen levels come down because they're not exchanging air. When you have pneumonia, there's all that fluid that's accumulating. How well can you exchange oxygen? Not well. So you're losing that area of the lung to exchange, so it makes it more difficult to breathe. Epiglottitis. Epiglottitis is bacterial. Anybody ever seen that? Probably not.
1967.
In a child or an adult? Child. So everybody knows the epiglottis, right? The epiglottis sits in here. Epiglottitis, it gets very swollen and it cuts off the airway. The interesting thing is, about 50-50 now, or 60-40, this used to be a disease of kids. You would see this primarily in children. But now, you see it more with adults. It's very, I don't know this firsthand, this is photograph. I actually saw it a bunch of times in the city. People from places like Taiwan, Vietnam, they get this in adults, as adults. And so you'll get somebody, I used to work in Lower Manhattan by Chinatown, and you would get an adult that got epiglottitis because they went back home. And then they came back, they got an infection, and they came back with it. So occasionally you'll see it in an adult. It's always important to ask about travel when you get somebody who gets sick with something weird, who doesn't have a history of something. So a question you might ask when something doesn't fit is if they traveled, or they'll tell you, I just got back from China, I just got back from the Middle East. And because diseases are different in different countries. But you can see this in adult populations. It actually is, I think now, more prevalent in adult populations than children. But classically, we teach it as kids.
In 1986, we came out with the vaccine. That's
Right.
why we're all protected.
Yeah. Yeah, you don't really see it in kids. You'll see this in adults from third world nations. That's where it's, Canada, actually, also, I saw one or two patients in Canada of Asian descent. Basically what happens is, it's like a golf ball, and it cuts off your airway and your ability to breathe. What do we do for it? Well, what do we do for it? Yes. The maximum transport. Pulmonary edema, we talked about this. A couple of causes of pulmonary edema. CHF is the chronic condition. So when somebody has, when you go to somebody's house and you say, what drugs do you take? They'll say Lasix or a diuretic. They say, I have CHF or congestive heart failure. When congestive heart failure gets bad and they can't breathe, then we call it acute pulmonary edema. CHF is the condition people have every day. Acute pulmonary edema is when they start to not be able to breathe because of it. Because people have congestive heart failure and they walk around, they go to work, they drive cars, they do everything every day. When they can't breathe is when it becomes pulmonary edema. Most common cause in the field of acute pulmonary edema with no history is heart attack. Somebody has a heart attack, part of the heart isn't working, and the fluid backs up in the lungs. You can also get acute pulmonary edema from, anybody ever done a fire? People breathe. If you had a fire, you breathe in toxins, that can cause the lungs to fill with fluid. Drowning, people who have near drownings can also go into pulmonary edema. I've actually seen that a couple of times. So a kid's in a pool, or even an adult's in a pool, they almost drown. You get them out, and they go, they're fine, and then all of a sudden, they have all this fluid in their lungs, and people think it's from the water, but it's actually not from the water. It's from pulmonary edema. Saltwater drownings. Somebody's in the ocean. This will occur. Salt gets in the system. What does the salt want to do? You guys have all done chemistry, right? What happens if you get salt somewhere? More water goes to dilute the salt, so that's basically what happens. Is if the salt gets in the lungs, the water dumps into the lungs to try to dilute it. And it can't be treated the way we treat it normally. It can't be treated with drugs. COPD, we talked about this. That's that whole bunch of diseases. Asthma, bronchitis, emphysema, all fall into the COPD profile. Are those diseases where air can't come in and go out? Out. Pushing air out. It gets kind of trapped in the lungs. Some people have, usually people have a combination of all this, especially when they're older. And most of it's from cigarette smoking. The other thing you may see it from is people who work in factories. So if you come to Stanford and somebody says, I work in a bakery. My whole life, I bake cakes, work with flour. In a room, an enclosed room, they can get COPD from working with flour. Or people who work in dusty environments, just regular dust. Dyspnea exertion, what's that? Take 3-4 steps and you can't breathe. So they call that dyspnea exertion. You'll hear, sometimes they'll talk to people and they'll say, you know, if you look at the question, sounds kind of odd. When you walk, you get short of breath. Have you seen that? So somebody calls you and they say at 3 in the morning they can't breathe. And then they start saying, when you ask them, well, what's been going on, they'll say, I walk up and down my stairs all the time. The last 5 days, I can't walk up the stairs without, and I can't catch my breath. So usually that's pulmonary edema or CHF. Limited activity, they're not able to move around a lot. Weight loss, bowel chest, that's all things that go with emphysema or bronchitis or emphysema. Pursed lip breathing, they breathe with their lips together. That's usually emphysema patients or bronchitis patients. Asthmatics will do that. It's called peeping. Usually not cyanotic. Anybody know why? I'm sorry? the air's inside of them, and they're normally short of breath. They've already, their bodies, because they've smoked for so long, now doesn't need as much oxygen. So for them to get flu, it takes a lot more. Coughs, smokers, we're through all this congested. Bronchitis, same thing, be either or. They cough, usually the sputum's always white, right? When they spit, it's white. What happens when it turns yellow or green or purple or some other Crayola box color? Infection. Blood. That could be from pneumonias, it could be from TB, it could be from a bunch of diseases. Dyspnea increases, so they start getting more short of breath. That's what we were talking about before, changes. Headache, why? Because they have no oxygen going to the brain, so the brain actually they get headaches. Respiratory distress, that's what we talked about. Tachypnea is what? Increased breathing, tachycardia, increased heart rate, increased blood pressure. JVD you don't see too much. It's kind of hard to see unless you know what you're looking for. That's when this vessel, this side of the neck, or on either side actually, but it starts to get large, that vein. But that's kind of hard to see because in some people you can see it when they're normal. When you listen to lung sounds, they have rales, bronchi, or wheezes. They have all these sounds that don't belong. What are the sounds like normally? Just plain flat, right? You hear air go in and air come out. If you have any abnormal sound, then that's a sound that doesn't belong. How do we treat them? Well, we talked about at the beginning. Oxygen, high flow, non-rebreather, sitting position, ALS required if available. I mean, you can always go to the hospital. You guys are actually really good at that. Where's the medic? Oh, he's not available? We're going to the hospital. I mean, I think you guys do that better than about any other squad I've ever worked with in my entire career. You guys actually get that. You go to the hospital. Monitor vitals and look for changes, right? That's what we do for any patient. Also, something to talk about. Asthmatics, do you have you don't? No. No. Spontaneous pneumo. So what's a pneumothorax? Hop lung. How does that happen? Could be by a rib, so it could be from trauma, it could be medical. If somebody has a disease like emphysema, they could actually pop a lung just by breathing. Somebody gets hit with a baseball bat in the chest and they break a rib, the rib can break their lung. How do we treat that? Hospital. What do we give them? Oxygen, sit them up in a position they can breathe. If they actually have a broken rib or anything like that, you can put a pillow against their chest to help them breathe better. Blood clots, pulmonary embolus. Pulmonary embolus can occur for a variety of reasons. It could be from flights, it could be from medications people take, it could be from blood problems, cholesterol. I mean, it could occur for a lot of things. The things you need to know: history, what happened today, and blood clots usually. I mean, the first time somebody has one, they wouldn't know, but a lot of people get them again and again. So they'll call you because they're short of breath and they've had them before. So when you picture the vessels, we talked about the oxygen exchanging, right? So if you have blood going into the lung or into the heart in any of those vessels that carry oxygen, and you put a big clot in it, and you prevent the blood from going, what's going to happen? You're not going to get any oxygen. So you're actually stopping the oxygen by preventing the blood from flowing. Does that make sense? That's what a blood clot, pulmonary embolus is. You're basically stopping the blood from flowing with the oxygen in it, somewhere in the lungs. So you can have a small one, or you can have a major one. If it's a small vessel, you'll be a little short of breath. If it's a major vessel, you might actually even stop breathing. pulmonary embolus generally is sudden onset, but that's not entirely true. They have shortness of breath, there's all these chest pain, coughing. Oxygen, ALF. Hyperventilation, and I think we'll stop with that. Hyperventilation. How do you know something's hyperventilation versus regular shortness of breath? Numbness